Hey again, everyone. Hope you're all doing well. We're on to our second online lecture of the semester, and we're going to talk about tissue healing. So let me get things rolling here. All right. What do you call a fake noodle? An impasta. And what do you get from a pampered cow? Spoiled milk. If I told you those already, I'm sorry. I'm pretty sure I told that to last year's class, but if I already told you those, just let me know and I'll try and come up with something better when we actually meet in person on Thursday. So, all right, so here we are. We're on to our second lecture talking about tissue healing. All right, here is a semi-better visual of the healing process than what's in your book. There is a typo because I'm pretty sure inflammation has two M's in it. That might just be me. So here's what your book talks about in some less specific terms. So they talk about the vascular phase. So hemostasis, that's trying to get bleeding to stop. Stasis of hemo, that's stopping of bleeding, blood. And we know that platelets are a part of that. That's not news. Fibrin is what's going to help plug up that hole and stop the bleeding. You get your proteoglycans in there, all your inflammatory factors. Then we go into what are your white blood cells and other factors doing to help clean up the area. And then you get into proliferation, starting to actually see some healing and finally into remodeling at the very end. So your book talks about this vascular and inflammatory response. You get this release of materials. What type of materials? You get histamine, leukotrienes, and cytokines. Those are all inflammatory factors. If you think back to, remember we talked about having the cell signaling pathways. So sort of like with the cell signaling pathways, those are going to infiltrate into the area, and that's sending signals through that big cascade of what all of the rest of the cells need to do. Leukocytes in particular, those are your white blood cells. So that's Leuko, sites, site meaning cell. So leukocytes are your white blood cells. Leukocytes have to be released. Those are your cleaning people, your environmental services. They're coming in to clean up the mess that was made by the damage. When you have this vascular response, so the vessel damage has occurred, and now what you have is a bunch of platelets that are going to come into the area and try and fill in the gap that has occurred in the tissue. So platelets are going to adhere to the collagen. So you got platelets here, collagen here, and those two start to play together, and you start to get your nice clot and fibrin plug to get everything going. This clot formation takes about 2 to 4 days to get a good clot going. During this phase, we're talking about managing inflammation. So we're trying to make efforts to inhibit excess swelling, but we don't want to be too aggressive about reducing edema. You want to manage it so that you don't have excess swelling, but some swelling is good. It happens for a reason. You have to have some swelling to get the tissue healing process to occur correctly. The issue with inflammation is that it does not have a good feedback loop. Once there's enough, there isn't a great signal to say, hey, cut it off, we're good. So we manage inflammation. That's where things like compression wraps and elevation come in. There is debate about ice and NSAIDs as your non-steroidal anti-inflammatory drugs. So Aleve, ibuprofen, ketoprofen, some of your different steroid drugs like methylprednisolone, also known as a Medrol dose pack. Those are going to knock down some of those inflammatory factors that you need to come in to clean up and get that repair process to happen like it's supposed to. So we want to manage the inflammation. We're pretty sure that compression is good. We're pretty sure that elevation is good. We're pretty sure that rest is good in these first 2 to 4 days while that nice clot is forming. But there is debate about the effectiveness of ice and NSAIDs. Does it actually delay healing because you're preventing the release of some of those different factors? Ice is great for pain management, however. All right, so let's move on. So here's acute inflammation. This would be some maybe excessive inflammation of a left knee here. I do not know what the injury was. I just grabbed an image online. So you can see, first things first, this is localized. So we have swelling, edema localized to the area of injury. If you can see this, the top of the knee here is red. So it's red, especially in comparison to the opposite leg and to up further on the thigh. If you were to touch this, it would be warm. It has sort of a boggy, squishy feeling to it, like a wet sponge. And that is what acute inflammation is going to look like. And the cardinal signs of inflammation, that's cardinal like the bird, cardinal signs of inflammation are going to be heat. So that's why it's warm to the touch. Redness, swelling, pain, and loss of function. You want to know these 5 cardinal signs of inflammation: heat, redness, swelling, pain, and decrease in function or loss of function. All that's going to be happening here with this nice big red swollen knee. Why do we want to know what the cardinal signs of inflammation are? Because as you go through the healing process, if you have your injury occurring here and up to the point of return to full function, it's not one linear path all the way. You get some jumping back and forth. And how do you know if you're inching back towards that inflammatory process? You see these signs of inflammation. So you want to remember the 5 cardinal signs of inflammation. Chronic inflammation, this is going to feel and look a little different than the acute inflammation. So in chronic inflammation, you can see here's the edges of this Achilles tendon here versus the edges of this Achilles tendon here. This one is not red. It appears swollen. It is not warm to the touch. I'm just going to tell you that. It still has pain. And there may still be loss of function, but you're missing the redness and the heat and that soft, boggy swelling are your acute inflammatory signs. Here, this is going to feel more hardened, sort of a fibrosis, more like squeezing an orange than squeezing a wet sponge. So that's what chronic inflammation is going to look and feel like. It does not mean it's not painful. It doesn't mean that it doesn't still cause problems and it doesn't hurt. But with chronic inflammation, you get this persistent breakdown in tissues. And when that happens, there's not enough damage going on to get the right chemical mediators to come in here and actually clean things up and start the healing process. You get a bunch of junk built up in here and you get these fibroses, and that's why this person has this big fat tendon here. So it still hurts, it still creates problems, but that chronic sort of low level persistent inflammation, you end up getting this buildup of fibroses, and that's that big fat Achilles tendon, that chronic Achilles tendonitis. So if we bump back here, I can show you that. So if you're not getting, if you're not getting enough of, let me grab my pen here. If you're not getting enough of the damage to bring in the macrophages, neutrophils, and such, you're not getting enough signaling from histamine, leukotrienes, and cytokines to actually clean up that wound. You just persistently get this buildup of these proliferative factors, fibroblasts, collagen, and epithelial, endothelial cells, but they're not building up for repair. They just keep building up because they keep coming into the area to try and repair the breakdown of the tissue without having enough of the cleanup going on. So that's going on with the chronic inflammation. All right, so I want to show you what is the deal with granulation tissue. Your book talks about granulation tissue and healing by primary and secondary intention. Here is, you've gotten through your, you've made some damage here, and you're getting into the point where now your blood clot is formed here. So here's your nice blood clot. And underneath here, this is your granulation tissue. So here, if you remember things like the basement membrane and whatnot, when you talked way back in the day in anatomy and phys about your layers of tissue. So granular tissue down in the basement layer, that's your granulation tissue sitting underneath there. So here we're going from, this is panel 1, 2, 3, 4. I know they're labeled A, B, C, D, but so here's your blood clot. Everything's blocked off. We've got all of those inflammatory factors coming in. So here's your leukotrienes, your cytokines, your histamine. You've got the white blood cells and your leukocytes coming in. They're starting to clean stuff up here on the edges. See this blank space now? So now we've got, go from blood clot to get a nice cleanup of the wound here by all those white blood cells. There's your scab, and you guys know if you pick the scab, then you see sort of that whitish, pinkish tissue in this area underneath. That's where you've had some cleanup. You have some granulation tissue that's starting to come up to the surface. Here we go. It's come up to the surface and it's healed at least this part of the wound so that it's not open to the underlying tissue. And this granulation tissue continues to fill in the space and the scar tissue forms, and you get a healed area of tissue damage. This granulation tissue, if you think about non-differentiated cells, means they're kind of there, they're part of your skin or whatever tissue is there. And as they start moving up towards a more differentiated cell layer, they start to try and mimic that. Depending on what tissue you're talking about, you're most likely going to get scar tissue. So here's your scar, but some tissues will heal with the same tissue. That would be bone in particular. As you go through the healing process, the way you know how to and when to progress rehabilitation is going to be based on signs and symptoms primarily. So that's where you're looking for your cardinal signs of inflammation. So SNS, signs and symptoms. Looking for those signs of inflammation, looking at what's the pain level that the patient's experiencing, but also you're going to know that the tissue healing process occurs in a somewhat regular fashion, though you can bop between phases. But if you have somebody who, their inflammation has gone down, it's not red, it's not that boggy, squishy swelling, they're not having much pain, they don't have much loss of function, their injury was just 2 days ago, you're probably not going to be getting into really aggressive exercise yet, because they probably tissue-wise still look something like this. It's a little fragile. You're going to give it some time to form a good base of healing where that granular tissue is starting to come up and create a stronger wound area. Primary injury, this image here is demonstrating a tissue like a skin puncture or laceration. That would be an example of acute trauma or macro trauma, so all happening at once, kind of a big thing, macro. But then micro trauma, that is going to be when you see that chronic inflammation, tendonitis, repetitive strain injuries. You've probably heard some of these terms before. So when you get that overuse, overusing something over and over again, something's getting irritated, that's that micro trauma. So you don't necessarily get the same big hemostasis vascular reaction, but hopefully you get enough reaction going on that you get the correct mediators coming in there to repair. In the repair phase, the processes that are occurring are all anaerobic. So this coming in of the blood clot and scab formation until you start to get into the phase where capillaries are reconnecting. So if you have, whoops, forgot to turn my pen back on. So if you have two damaged tissue ends here, here's your granular tissue underneath. At the point where this granular tissue is still kind of moving up, you've got that blood clot going on. The capillaries that were here are damaged. So let's see, that's capillary, and it's not connecting across. Once those capillaries come in and infiltrate, now you have blood supply and you get more tissue healing going on. So it's an anaerobic process until those capillaries come in and infiltrate the wounded area. Your granulation tissue is going to come up, differentiate into the tissue that you need there. And eventually collagen fibers are what are going to lay down. They will first lay down in a random fashion, just trying to get things healed up and reconnected. Then over time, as the healing process goes on, depending on what the forces are on the tissue, the collagen fibers start to line up a little bit more regularly, and you get a stronger wound healing area. Like I said before, with chronic inflammation, you start to get that collagen fiber deposition over and over and over again. And you get too much and you start to get too much collagen laid down. You get that thick fibrosis. It feels like squeezing an orange versus squeezing a squishy sponge, which is your acute inflammation versus chronic inflammation here. In the maturation phase, so now you have your collagen fibers have started to lay down and do get the wound area to have a little bit more strength to it. Now you get into the maturation phase, also known as the remodeling phase. If you remember Wolff's Law says that you have your tissues will increase their tensile strength along the lines of force. So remember I said before, collagen will start to lay down in sort of a random fashion. Well, let's say this is a tendon that's running in this direction. If you have force being applied along the tendon in that direction, then eventually those collagen fibers will start to lay down in a more linear fashion versus being random when the tendon is just at rest. So that is why mobilization is such an important thing. Controlled mobilization, meaning we're moving the injured tissue in a controlled manner, is superior to immobilization. Total immobilization is recommended only for a few days. Immobilization. My pen is getting mad at me for drawing too much. This is going to be a matter of days, not weeks and weeks on end. When there is a type of tissue repair that needs total rest and immobilization, those situations do occur, but controlled mobilization is going to start very early for most injuries, for most healing processes. How much is too much? First thing you're going to think about is pain. Can the patient tolerate the activity? Remember I said before, my rule has always been a 4 out of 10 or less. We try and work through it because sometimes you got to do the hurt so good or work through a little bit of pain to get to a higher level of function. But you want to monitor for signs of a new inflammatory process. So we're going back looking at, are you seeing those cardinal signs of inflammation, the redness, the hot, boggy swelling, pain, and loss of function? If you are, then that may have been too much. And so you're going to back up, go back to a little lower level, a little less intense, and let that new inflammatory process resolve itself. And then you try and increase again. If you look in your book on pages 36 and 37, they have a whole list of factors that impede healing. I recommend reading through that list so that you have an idea in the back of your mind what a patient with some different factors might look like when it comes to the healing process. So make sure you take time and look through pages 36 and 37 in your book. So let's talk about some specific injuries and what they look like as they go through the healing process. So ligamentous injuries, remember these, let me get my pen here because this is important. Come on, pen. So these are sprains and not strains. Strains are for muscles, sprains are for ligaments. So we want sprains here, not strains, sprains. All right. They are graded on a scale of 1 to 3, with 1 being some separation or stretch of the fibers. Grade 2 is your partial tear, and grade 3 is your total ligamentous rupture. So the ends are not touching each other anymore. What happens with healing? If you have a ligamentous injury, here's your macrophages coming in, doing their job to clean things up. They drew nice little Pac-Man here. It's going to eat up the nasty destroyed part. Then here's your growth factors. That's your cell signaling pathways. Fibroblasts coming in, starting to fill up the area. That's now nice and clean thanks to your macrophages. Here's your fibroblasts that have now filled in the area. You get that collagen laying down and you have scar tissue, and now awesome. Look at that. Your ligament is healed. So here's a timeline. Your inflammatory phase going about 3 days. Within that 2 to 3 days to 6 week stage, now you have proliferation and you end up somewhere around here. Then 6 months to a year out, you're still getting some remodeling and maturation of that ligament. So this 6 months, if you know somebody who's had a ligament tear, yes, they're back to function within maybe 6 to 8 weeks, but that ligament is not fully healed and strong for probably 6 months or greater. When you think about ligament injuries, you probably think about an ACL, your anterior cruciate ligament. And if you look at how this injury healing is outlined here, that's not what happens with an ACL. So here's your ACL, the one in the front, anterior. When you have intra-articular ligament injuries, so within the joint capsule, they will not grow together if the ends are totally ruptured. So here's 2 totally ruptured ends. Think if that happened to here on the ACL, when those ends rupture, the 2 ends can't be bridged by that granular tissue. So that is one of the reasons that ACLs are typically repaired with a surgical procedure where they actually come in, they drill a little tunnel here, and they run a new piece of tissue through here to act as your ACL. Other extra-articular ligaments can heal when those 2 ends are bridged by granular tissue. So here's an image of that. If this is a MCL, because here's your fibular head, so it's going to be lateral. So MCLs frequently, when they're torn, You do some controlled immobilization. That granulation tissue comes in, lays down a nice scar, and eventually you have enough strength in that tissue to return to activity without needing to have surgery, even though it can take up 6 months to a year. There's debate about whether or not the surgical options for repair are better than just leaving the tissue to go through its typical healing process. Um, there is a benefit to surgery that you have a increase in the tensile strength of the tissue sooner if you have a surgical repair. But when you have a surgical repair, there's some damage to the nerves that happens when they go in and create even more damage with creating the little portals that they look in with the scopes and such. Um, that has to heal as well, and there's a loss of joint position sense. If you don't have good joint position sense and your proprioception is poor, then are you more likely to be re-injured? Or are you more likely to be re-injured if you don't have surgery and maybe the tissue isn't as strong earlier? So there's debate. Typically, if a ligament has been known that you can do some controlled immobilization, a scar will lay down well. You slowly add in more mobility to this joint, and the collagen lays down in a nice organized fashion. Then surgery is not recommended unless there's some other crazy damage here, like to the meniscus. But when you have an intra-articular injury, like here to the ACL or the PCL, the PCL is not always repaired, then you um, are more likely to repair that surgically. I'm just going to look at my notes here and make sure I remember to tell you everything I wanted to. During the maturation phase, because we talked about this is 6 months to a year, so maybe somebody goes back to play after 8 or 12 weeks. That's where you're protecting with some sort of bracing, taping, some sort of protective method so that all of the force of the activity isn't being borne on this healing tissue. You can use some sort of bracing or taping to assist and give some support. All right, that's ligamentous injuries. Cartilaginous injuries. This is looking at the bottom of the femur. Let me pull my pen back up here. I wish it would stay on. If you're looking at the bottom of the femur here and the top of the tibia, sorry about that. So here's your tibia articular cartilage, same on both sides here. There's your femoral articular cartilage. This is what your articular cartilage is supposed to look like. Here is a defect in the cartilage. Here is a defect in the cartilage. This one here is showing this is a meniscus starting right here. Articular cartilage is your meniscus. So that defect, you can see it's kind of fuzzy looking. In this panel, you can actually see where it has worn into the bone. So you're seeing some of the ends of capillaries there. That's why it's looking red. So that is what a cartilaginous injury looks like. Articular cartilage and menisci and such are notoriously poor healers because they don't have a great blood supply. If you don't have a good blood supply, then you can't get those healing factors to come in and do their job. So your leukocytes, your leukotriene, cytokines, histamine aren't going to come in and start those cell signaling pathways like they should. And then you don't have granulation tissue coming up to fill in and fix issues like this in articular cartilage. One way that this is addressed is that you increase strength of the surrounding muscles, and this is an example of mechanical unloading. So if somebody has a pen again. If somebody has a lateral issue with the hang on, let me start over again here. what this is demonstrating is that here, see this bone on bone here? That would be occurring here where I've drawn the circle. Sorry, the brace is opposite of what the picture looks like. You have that sort of squishing together. If you had an articular injury here on the surface, that would be very painful. These type of unloading braces, it's going to apply a force here, here, and here. Just sort of push the knee over. So you can see this arrow here. It's showing that it's pushing the knee over. So now see this joint space is smaller. This joint space is larger. So here is a big joint space where over here you had bone on bone before. That sort of mechanical unloading can relieve some of the pressure on that articular cartilage so it's not as painful. Doesn't fix anything necessarily other than maybe preventing it from getting any worse and giving some pain relief. To actually repair, you do something to bring in new granulation tissue and cause healing to occur. So this is called an Oates procedure. That's whoops. Get my pen back. So Oates, O-A-T-S. That's an osteochondral autograft or allograft transplant surgery. So osteochondral autograft or allograft transplant surgery, meaning either it's an autograft, that means it comes from you. So they take some plugs of articular cartilage from an area that's not weight bearing. This is just kind of where your patella runs, and they donate it to the area where you had damage. So that's what's shown here. They took some plugs from up here and they plugged them in down where the defect was. That's an autograft. An allograft would mean that they took somebody else's tissue, somebody else's articular cartilage with this nice underlying membrane of all your capillaries and granulation tissue that's going to come up, fill in all these spaces here, and you get some more healed articular cartilage. So that's one method of healing, because you have to somehow get that inflammatory process to start, get vasculature to come in and bring in the appropriate factors to do some healing. This is called microfracture, also known as a Stedman pick procedure. Stedman is I keep thinking the pen is on, sorry. Stedman is Steadman. If you've heard of the Stedman Clinic, that's him. So Stedman pick procedure. What they do is they go to where that defect is. They try and clean up the fuzzy edges a little bit, and then they drill little holes into the articular cartilage so that you get some bleeding, you get some of that granulation tissue to come up and hopefully start to fill in where that defect was. You see this big defect here. They poke some holes in it. That's where the pick comes from. And that helps to bring in some of those healing factors and granulation tissue to actually repair some of that articular cartilage. Bones are your best healers. Their bones are the ones that actually will regenerate themselves, and you end up with bone again versus scar tissue. So if you have a bony injury, here's your inflammatory phase. And you can see this must be anaerobic because the capillaries are not connected in there. So you get that hematoma formation, nice blood clot, macrophages and leukocytes come in and debride the wound. Then you get to the soft callus phase. That inflammatory process is going to signal cell division. You have your available tissue to have cells differentiate into the factors that are needed. And you get, here's your angiogenesis, so your capillaries coming back in, able to bring in more nutrients. And you have your chondrocytes. You're within the bone. If you remember how bones grow, you have chondrocytes, and they're going to secrete the appropriate collagen to start to lay down collagen and create fibrocartilage so that you get this, you have this soft callus here. And then over time, you get endochondral within bone ossification, and you get this hard callus. So over time, the hard callus develops. And then remodeling, again, along the lines of force, Wolff's Law, you have bone develop and you end up with this area of healed bone. So bones are your best healers. To muscle injuries, so now we are talking about strains and not sprains. So muscle strains, they still follow the same grading as ligaments. So grades 1 through 3, with 1 being some separation of the fibers, 3 being a total rupture. So here's an example of a hamstring tendon rupture. So this wad of muscle here should be extending up along the leg. They had a rupture from somewhere, maybe along at the ischial tuberosity. That muscle has now crept down because it's not attached where it's supposed to be. So that would be a grade 3 total muscle tendon rupture. Otherwise, this will definitely start to look like this eventually too. This looks pretty fresh, or it's very old and the ecchymosis bruising has already gone away. When somebody has a muscle strain, you have rupture of that tissue. You also have rupture of the blood vessels. So there's your blood vessels. Here's your injury. There's gonna be bleeding, and you see this would be a hamstring strain, and this area of bruising is the blood that has come from the damaged blood vessels kind of pooling in the direction of gravity on the back of the leg here. So if here's your nice healthy muscle, if you have an injury to that muscle, here's some separation of the fibers. Over time, that scar tissue comes in and heals the wounded area. That's not muscle tissue, it's scar tissue. So what we care about here is that when the person is healing, remember that you want to apply force along the line of pull of the muscle so that you have collagen laying down in a more organized fashion. The better you can get that collagen to lay down along the lines of force that that muscle withstands, the stronger that healed tissue will be. So we apply force during the healing process so that collagen's laid down in a more appropriate manner and you have better tensile strength of that muscle once it heals. With ruptures, you don't always see a rupture. You may see a rupture. Achilles tendons, biceps, your elbow biceps. I'm having a total brain fart this morning. And are the probably most common ruptures. Achilles tendon is probably the most common. I have seen a quadricep tendon rupture, a distal quadricep tendon rupture from somebody falling down the stairs with their foot tucked up underneath them. And I have also seen a pectoralis major rupture. And what you end up seeing is you find a little balled up bunch of tissue. First of all, they have pain. They have some loss of function because that muscle's not attached anymore. And eventually you see this big area of ecchymosis and swelling. This is very palpable. Other grade probably 2, high grade 1 and grade 2 muscle strains are also have palpable defects. You can feel sort of where the injured tissue is at. It doesn't feel like the rest of the muscle. Those are your muscular injuries. Hey, tendinopathies. I believe Microsoft Word tells me that both of these are wrong, but whether this is a tendinopathy or a tendonopathy, I am not sure. So I'm going to have to phone a friend on that. Tendinopathies. We talked about you have this degeneration in the tissue. You're not getting enough inflammation to really clean it up and get good tissue maturation and laying down of appropriate cartilage along the lines of force, you just get that buildup over time of lots of fibroses. So this is an example of a patellar tendon, and you can see some of these chunks of tissue. Those are those fibroses. They start to lay down over time. You don't have a nice, smooth, pink, healthy looking tendon. You get this sort of silver skin looking fibrosis that builds up over time. And that's what's going to, when you squeeze it, it's going to feel more like squeezing an orange than it does that boggy, acute inflammatory tissue. Over time, you can develop crepitus. So crepitus, if you have inflammation in a tendon, that tendon doesn't slide through the synovial sheath as well, and you get a creaking sound. I had de Quervain's tenosynovitis, which is in your thumb, and every time I moved my wrist or my thumb, it sounded like a haunted house door. It literally creaked. It was very freaky, but it really does happen. The more chronic tendonitis, sometimes you do different massage or tissue mobilization techniques to try and relieve some of these adhesions, and maybe even purposefully cause some greater inflammation so that you get better healing. With more acute tendonitis, that's sort of acute repetitive strain injuries, people who start texting a lot, people who are playing a lot of video games suddenly. Those often, if you rest, give the tissue a chance to go through its inflammatory process, clean up some of the junk that has happened. You can have good healing in the muscle, especially if you focus on what was the body mechanic that caused the issue in the first place. So if somebody is squatting and they're on their toes all the time, so they're going to start a weightlifting program, they're doing a bunch of squats, but they're not leaning back into their heels. They're putting a lot of excessive pressure on the front of the knee, and they start to get this gross patellar tendonitis. Some rest, address the body mechanics. So inflammation is going to go down with the rest. You get good healing, and you address the body mechanic that caused the issue in the first place. Then you have a good outcome. If you already are dealing with the chronic inflammation and these development of these fibroses, that's where you go into managing some of the fibroses with some tissue massage or soft tissue mobilization techniques, which we'll talk about more this semester and a lot more this summer in 500. If you have nervous tissue injury, nerves are not the greatest of healers. In particular, if you have damage to the cell body, so here that's your, with all its little projections on it, damage to the cell body, then that nerve is not going to regenerate. If you have damage along the distal portion of the nerve, so here this is showing an injury somewhere in the middle of that axon, you can get regeneration back to the original point of innervation. They are very slow healers, though. They heal about 3 to 4 millimeters per day. So wherever that point was, you're going to get growth back towards where the innervation is supposed to occur. 3 to 4 millimeters per day. So depending on where the injury was and how far it has to go, sort of people end up having sort of little numb spots for a long time, or the area just doesn't feel the same as the surrounding tissue. Eventually you can get regrowth of that axon back towards the area of innervation if the cell body is preserved. Contusions, just to point this out, here's somebody who got hit by, I don't know, a baseball or softball or something. I don't see the stitching on it, but with contusions, it's mostly managing the amount of cellular debris and old blood clots and whatnot that are going to hang out in here after the period of damage. So are doing controlled mobilization, trying to keep that tissue moving so that you have good blood flow and you're able to get white blood cells in there to clean this up and move stuff out. If not, and if you have repeated contusions, that hangs that cellular debris hangs out in there and starts to ossify, and you can get myositis ossificans. So that's a development of ossified tissue, so bony tissue within the muscle from repeat contusions. All right, what do we do for therapeutic exercise depending on the phase of tissue healing that somebody is in? If somebody is in the acute phase, we're here in the bleeding, getting a good blood clot formed into that early inflammation phase. You're managing edema, managing pain, not going too crazy with ice and NSAIDs, but trying to manage pain and prevent excessive swelling. So we get into the repair phase. So here we're in inflammation, then remodeling and proliferation come next. I like how this is drawn, that you have some proliferation of cells early in the inflammatory phase, and you still have some inflammation as your proliferative phase is going on. So they're not distinct phases, but as you're moving from inflammation into proliferation and you're getting some repair, you're trying to maintain that person's fitness level, not let them get too couch potato-y as they heal, or restoring and retaining range of motion. As much as possible, you're retaining range of motion. If there's a period of immobilization, then we're trying to restore range of motion, and also restoring that position sense and proprioceptive ability. And into the remodeling phase, which is going to come here. So here you actually have some overlapping of all three. Yes, it happens, but as you get more into the weeks and months of healing, now we're into remodeling, and you're focusing on those functional skills and applying tension along lines of force so that you get the collagen to lay down in an appropriate fashion to increase the tensile strength of that healing tissue. Throughout, you're monitoring signs and symptoms for in going backwards. So if you're starting to see those cardinal signs of inflammation, and maybe you're moving a little bit too fast on the rehab process, so slow it down, let that proliferation phase pick back up again into remodeling. There is definitely a possibility of kind of going back and forth between these phases as you start healing and start getting back to normal activities. Healing can take 6 months to a year, in particular for ligament injuries. So if you have somebody who's going back to activity after a ligament sprain, maybe you saw them for 6 weeks, so you're here and they're kind of ready to go back to their daily activities. This is where patient education comes in. So you know the signs of inflammation. You want your patient to also know signs of inflammation. So if they start to see redness, swelling, they have pain, they're losing function, maybe then they know that they need to back off a little bit, give it some time to heal, and get back into that proliferation remodeling phase, and then they can start to try and pick it up again, because you're not going to see them for a full year or multiple years, most likely. So that's where your patient education comes in. All right, that's all I have to tell you about tissue healing. We will talk more in class. Please bring your questions for our small group discussion. And otherwise, I hope you all have a great day, and I look forward to seeing you during your small group discussions.